It is my yeah. It's my real pleasure to introduce today Dr. Audi Setiadi to you. Audi has been working at Children's Hospital since the fall of 2019 and has really accomplished a lot in that short time. And she will present her kind of flagship today on the immune system and flow cytometry. Audi is a hematopathologist at Children's Hospital, and she earned her undergraduate degree in cell biology and genetics at UBC and a medical degree at McMaster's in Ontario. She completed her residency in Hempath at UBC. During her time at BC Children's, she has been actively involved in the implementation of new flow cytometry panels for mostly primary immune deficiency and HLH. They're also working on acute leukemia and very exciting in the cellular therapy lab. We're doing lots of graft manipulation processes, and Audi's been very much involved in that, including the flow cytometry needed for that. Audi has been instrumental in the implementation of the flow cytometry assays for the SCIP newborn screening. It has been expanded recently. She sat on the SCIP's newborn screening committee at BC Children's and worked with the biochemical geneticists and clinical immunologists to establish the flow cytometry referral processes for newborn screening. And I'm not going to take any more time from you. Audi, go ahead.
Thank you so much, Suzanne, for the kind introduction. I'd also like to thank you, Suzanne, and our clinical immunologists who are part of the initial planning of this project and for giving me the great opportunity to participate in this project. Wouldn't have happened without you all. So without further ado, I'm going to talk about the implementation and expansion of flow cytometry panels for primary immune deficiency at BC Children's Hospital. I have no conflict of interest. I'm a hematopathologist by training, not a clinical immunologist, but we're very lucky to have a strong collaboration at our center where we learn from each other to make this happen. So in this presentation, I'll start by giving a quick introduction about primary immune deficiency, or another name is inborn errors of immunity, which or IEI, which is a term that I will continue to use throughout this presentation. A bit of overview of TNB cell development and role of flow cytometry for investigation of IEI. And in response to the demands from our clinical immunologists to expand our immune deficiency assays in-house and to support our newborn screening for SCID in British Columbia, which went live last October, we implemented the extended TB and NK flow cytometry panels. We'll talk about that and their clinical utility, as well as our 3-year experience here with real case examples. So inborn errors of immunity, or IEI, is a heterogeneous group of disorders that result from intrinsic defects affecting development and or function of the immune system. So the clinical presentation can be quite variable. Patients with IEI are susceptible to developing severe infection, but also a significant percentage of patients may also have signs of immune dysregulation, such as autoimmunity, atopy, and lymphoproliferation. And as you can imagine, the differential diagnosis for these conditions are quite broad. And there are a lot of them that are associated with not inborn errors of immunity. And, you know, as an individual disorder, they're actually historically considered rare, but their true prevalence may actually be more common, especially as more entities were described and clinical phenotypes are defined more precisely. And in aggregate, the prevalence of these conditions actually about 1 in 1,000 to 1 in 5,000 individuals with an incidence of about 10 in 100,000. If you compare that, the incidence of leukemia is really not that much less common. And with the advent of next generation sequencing led to the identification of an increasing number of genetic defects for IEI and over the years, over the recent years, and there are different number of genes associated with each of the categories in IEI. with more than 400 entities now identified. But this also poses kind of like a problem because there are a lot of novel mutations and so-called variant of uncertain significance that may or may not be responsible for the patient's phenotype, and that really needs some kind of phenotypic validation to demonstrate that it is affecting the immune function. And another problem is that the underlying mutations may not always be identified. The diagnostic rate is reported at less than 50% currently. And this graph is showing you the prevalence of physician-reported IEI, which has really grown over the last few years. So because of the wide range of the clinical manifestations, these disorders can lead to significant morbidity and mortality and can pose significant burden in our system if left untreated. So early diagnosis and clinical management is really important prior to development of severe infections. You might have seen this warning signs of 10 warning signs of primary immune deficiency, which include repeated ear infection, sinus infection, antibiotics with little effect, requiring IV antibiotics to clear infections, failure to thrive in an infant, and so forth, and so on and so forth, or a family history of primary immune deficiency. And the accurate diagnosis is really important and have critical implications on therapy. For example, timing of stem cell transplant, like individuals with SCID can be cured with transplant before age of less than 3.5 months for the best outcome. And after that, there are studies showing that the outcome is not so good. And as soon as these conditions are suspected, there are a few other supportive measures, such as avoidance of live vaccine and breastfeeding to reduce the risk of CMV transmission, for example. Blood products that the patient receive has to be irradiated to prevent transfusion-related GVHD. And it will have also impact on IVIG utilization. It used to be like every single suspected PIDD is treated with IVIG, but nowadays there are a lot more emerging targeted therapeutic agents to address specific disorders. So this is showing the current classification of IEI according to International Union of Immunological Societies committee. It's divided into 10 groups, which I categorize here as a defect in adaptive immunity versus innate immunity. So the adaptive immunity, which involves T cells and B cells, we have the predominantly T or combined immune deficiency. The poster child for that is SCID, or combined immune deficiency with associated or syndromic features like dyskeratosis congenita, DiGeorge syndrome, and others. Predominantly antibody deficiencies that affect the B cell maturation pathway. A classic example of that is common variable immune deficiency or CVID, hyper IgM syndrome, etc. And there are disorders of immune dysregulation, which involves autoimmune lymphoproliferative syndrome or ALPS, as well as HLH or familial HLH. And there are disorders under innate immunity defects, such as phagocytic defect, like an oxidative, CGD or chronic granulomatous disease, which affects the function of neutrophil to generate oxidative burst. And there are also others that I'm not going to touch in this presentation. And then there's also a new category this year or last year, which now include also bone marrow failure syndromes, such as Fanconi anemia and dyskeratosis congenita. So I don't think we can talk about IEI without thoroughly understanding about T and B cell development. And I think a lot of you have some background in immunology, but I just want to do a quick overview of T cell and B cell development to make sure everyone's on the same page. So the progenitors of T cells from the bone marrow mature to the mature in the thymus. And they started as a double negative subset, which is 4 negative and 8 negative, and do not yet express T cell receptors. And then it develops into double positive T cells, which express CD4, CD8, as well as TCR alpha beta. They then undergo negative selection process where those T cells that too strongly bind to self-antigen as presented by MHC complex, or if they do not recognize MHC peptide complex, get eliminated, and the rest of them develop into single positive T cells, where it's CD8 positive or CD4 positive. And then there's a small subset of CD4 positive T cell that develop into regulatory T cells as well. And then they further undergo negative selection in the medulla as mediated by medullary epithelial cells. There's this transcription factors called AIR, which is expressed in the medulla that induces low-level expression of many antigens that are normally expressed in the bodies, so-called tissue-restricted antigens. It basically exposes the T cells to normal healthy proteins from all over the body, and the T cells that react to those proteins are destroyed. And if they pass the selection process, then they circulate the body as either CD8 cytotoxic T cells or CD4 helper T cells or regulatory T cells. So it's very oversimplified diagram, but essentially naive T cells, after positive and negative selection, they circulate the body, each with their own unique epitope specificity. They then encounter antigens, they get activated, differentiate into specific subtype, expand, and fulfill their role as effector cells in various tissues and organs. And following antigen clearance, the majority of these T cells die, while a small pools ultimately develop into a long-lived memory T cells. So this is just a showing different stages of memory T cell development. So most T cell subtypes can undergo memory differentiation steps after activation by their antigens. Each subtype have different functions and have different properties and can be identified using different cell surface markers. So the T cell that just recently exit the thymus is called recent thymic emigrant, which is really the true naive T cells. They have the highest number of TREX, which is T cell receptor excision circles, which is a small circular DNA molecule that's generated by T cells as they rearrange their T cell receptors during development. And they also have the longest telomere length. Basically, they have like a huge regenerative potential. And then there are also central memory T cells, which express a homing molecule, CCR7. So they home actually in central lymphoid organs or in the lymph nodes. And they have brisk proliferative response when they re-challenged by the antigen, and they give rise to many effector T cells. The effector memory T cells, in contrast, they home to peripheral tissues and provide rapid effector function and rapidly become cytotoxic upon antigen exposure. And so they display a lot of these activation molecules, CD27, CD28, and then eventually they develop into this more like a senescent subtype, which is called TEMRA, or these effector memory re-expressing CD45RA, which displays a lot of the molecules associated with senescence or exhaustion, like PD1, CD57. And this sort of like a terminally differentiated subset has the least number of TREX and the shortest telomere here. So the B cells develop in the bone marrow. They rearrange their receptors like the heavy chain followed by the light chain, and eventually they form this B cell receptor, which is IgM in nature. And the immature B cells exit the bone marrow and circulate the periphery, and what's called transitional B cells. They're on the journey or in transit to the spleen or lymph node. And when they're in the lymph node, they then differentiate either into marginal zone B cells, which participate in the T cell independent antigen response, give rise to short-lived plasma cells, or they give rise to follicular B cells, which participates in T cell dependent pathway, and in germinal center reaction, they class switch into memory B cells, which can be IgG or IgA, IgE, and so on and so forth. And these switch memory B cells then can give rise to long-lived plasma cells, which then home back to the bone marrow. So each of these subsets can circulate in peripheral blood at some time, and they can actually be identified using different cell surface expression. So any mutations or defects that affect the developmental pathway of these T and B cells can give rise to immune deficiencies and adaptive immunity. So, for example, SCID, in severe combined immune deficiency, the defect happens really early in the development of T cells and B cells in the bone marrow or thymus. So there is no naive T cells or B cells that exit into the circulation. And the defect can happen much later as well. For example, in the B cell maturation or differentiation pathway. For example, CVID or hyper IgM syndrome, there is a defect in class switching of the B cells, and as a result, they don't develop into plasma cells, and the patients have very low number of immunoglobulins. So given the diversity of the immune system and variable clinical presentation, we really require a wide array of diagnostics tools for the accurate diagnosis. So often, the initial assessment of a suspected patient with immune deficiency begins with, of course, history, basic blood work, serum immunoglobulin levels, and TB NK cell count. And sometimes the definitive diagnosis requires genetic testing. However, as I previously mentioned, there's a long turnaround time, can be quite expensive. The underlying mutations may not always be identified, and there are a lot of variant of unknown significance that needs phenotypic validation. And for those reasons that you also need some phenotype analysis, which is provided by some of the flow cytometry assays we're going to talk about, such as T and B cell subset flow cytometry, lymphocyte proliferation testing, NK cell cytotoxicity, and others. So just going to talk about the update in our flow panel for immune deficiency in the next few slides. So we really build on the existing flow assays for TB and NK cells. We already have other complementary assays in-house, such as lymphocyte stimulation assay, which assesses the function of T and B cells, as well as the ALPS panel that constitutes of the T cell receptor analysis. As well as, so building on these, we established a testing for these more expanded T and B cell naive memory subsets, as well as NK cell perforin. So this is showing the currently established in blue, that's already in place at BC Children's for a long time, which is the basic TBNK, as well as the oxidative burst assay for CGD and T cell proliferation assay. And then the new panels that we're going to talk about, the more extended subsets of T and B cells, as well as NK cell perforin assessment for HLH. So flow can not only provide information on the cell surface markers, but it can also do intracellular protein analysis as well as functional. So all these three assays are often complementary to each other. And this is showing our flow panels for the extended T and B cell memory subsets, which include, of course, the T cell lineage markers, CD45RA, which is the naive T cell marker, as well as other, markers of T cell activation, 27, 28, and markers of T cell exhaustion, CD57, PD1, and B cell tube, we have like the regular B cell lineage marker, as well as some activation markers like the 21, which is very helpful to delineate autoreactive B cells, 24, 38, which are also other activation molecules, and memory B cell marker, which is 27, and immunoglobulin receptors. So I think a very important concept is also that the proportion of these lymphocyte subsets are not the same across different age groups. So at birth, the majority of compartment composed of naive T cells, and as they gain more antigen experience, they get activated. Memory T cells become a more abundant subsets, especially after the thymus involutes after puberty. And similarly for B cells, the majority of the subsets are naive at birth, and then they slowly gain more memory B cell subsets. So this really highlights the importance of age-specific reference range for different lymphocyte subsets. So you cannot just take a reference range for teenagers or adults and apply it to a younger kid, for example. And this is an example, our in-house examples of our normal cohorts at the top here across different age groups. So this is automated APS, or automated population separator plots, which use information from all the parameters in flow assay to cluster different cell populations. So as you see here in newborn, naive T cells in green are the most prevalent. It's the majority of the T cell subsets. And as you age, the central and effector memory T cells in pink and yellow here become more prevalent. And then TEMRA, which is the more senescent subsets, is of course more increased in the adults compared to younger kids. And then this is a plot of a patient with combined immune deficiency. As you see, the proportion of naive T cells markedly reduced compared to the normal. And then this is for B cell subsets. Again, in the newborn, the majority of B cell subsets are composed of naive and transitional B cells that just exit the bone marrow. And there's very little in the way of any switch memory B cells in purple. And as the person ages, the switch memory B cells then become more prevalent. It peaks at around age 1 to 5 and plateaus after. And these are at the bottom here, plots for different patients with different immune deficiency. So this is a patient with immune dysregulation defect, or CTLA4 haploinsufficiency, where they have an expansion of C21 low, 38 low autoreactive B cells in green. And like this is a patient with B cell maturation defect, PI3 kinase delta mutation, where the patient has an arrest of maturation into kind of more like the naive and transitional B cells, and they have reduced B cell maturation or class switching. And this is, of course, a patient with CVID with markedly reduced switch memory B cells as well. So there are quite a few sources as well of variability and things that have to be kept in mind when we do lymphocyte subset immunophenotyping. It can be affected by multiple pre-analytical variables, including sample age, anticoagulant transport conditions, and even the staining protocol, how many times you wash, can lead to different results and percentages. And also, panel design is also important because there are multiple ways you can actually define different T and B cell subsets. And depending on your gating strategies, you can have actually slightly different percentages of these different subsets. And for certain populations, there are complexities in gating as well. So there are a few steps we did to minimize this variability, including dry antibody reagents and standardized protocol for immune phenotyping. Here, which is we inherited from one of the groups in our research center. And we always review the gating prior to releasing the results, just as a secondary check. And we also have this continuous education and regular case reviews with our clinical immunologists. And so far they're happy, thankfully, and creation of in-house normal reference images, which is I'm hoping to do next in the future. So this is one of the in-house studies we did on the effect of storage and anticoagulant on T and B cell flow cytometry. I think a lot of the cutoff that we use, like 24, 30 hours, are derived from the HIV studies. But we wanted to look at kind of like on a deeper subsets. What are the cutoff where you start to see like significant change in expression and whether there's any difference between anticoagulants. So this is one of my summer students worked hard on this project, and these are the results. So similar to what has been previously shown, CD4, CD8 T cells start having a significant degradation or change in expression after around 48 hours. But the T cells are in general more resilient compared to NK cells, for example, where there is a significant degradation after 24 hours, and in certain subsets of B cells as well. So of course, when we get samples from all over the province, it's difficult to say like, oh, for B cell, this B cell subset or that T cell subsets, you need different time limits, practically speaking. So we just kind of put a hard cutoff at about 30 hours for sample to be received. So in the next few slides, I'm just going to talk about different utility of these flow panels in clinical immunology. First and foremost is the confirmation of abnormal newborn screening for SCID. So SCID, or severe combined immune deficiency, is characterized by a profound T cell defect, and depending on what type of mutations can also be associated with B cells and or NK cell defect. The incidence is about 1 in 70,000 in non-First Nations, and actually, interestingly, much more common in First Nations than in the study done by actually one of our clinicians. So typical presentation for SCID is usually within 6 months of life, characterized by failure to thrive, persistent diarrhea, severe infection, signs of GVHD and profound T-cell lymphopenia. However, there are also atypical presentations where you do not have decrease in T cells, so the T cell count and lymphocyte counts are actually normal. Examples of that being leaky or variant SCID, Omen syndrome, and sometimes the T cells from the mom can actually engraft in the baby. So you can actually look at the flow and it looks like they're T cells, but it's actually T cells from the mom, not the baby's T cells. And it is a medical emergency and needs to be referred to clinical immunologist and transplant as soon as possible. And the stem cell transplant is really the only way to cure this disorder. So because of that importance in diagnosis, we have a newborn screening for SCID, which went live last October. And similar to other newborn screening for other conditions, it's done through dried blood spot, where you extract the DNA and run the PCR. It's done at our biochemical genetics lab. And there's this T-cell receptor excision circle, or TREC, which is a small circular DNA molecule generated as T cells rearrange their T cell receptors that can be detected using PCR. However, abnormal TREC result does not always mean SCID. There are other non-SCID conditions that can lead to abnormal TREC, and this is newborn screening experience from California, where they look at all the babies with abnormal TREC, and as you see here, there are other syndromes that can lead to low TREC as well, such as the George, trisomy 21, other congenital disorders, as well as preterm babies. So as you can imagine, the management of these different disorders can be quite different. And if you're a true SCID, that you need a stem cell transplant, whereas others, you may just need like some supportive measures. So they detected the incidence of SCID in about 1 in 65,000. So kind of similar to what's described in Canada. But the non-SCID T-cell lymphopenia is much more common than that. And that's the reason why we need flow confirmation of the newborn screening for SCID. And that really has been a standard of care in other North American centers. This is an algorithm from Ontario that we kind of follow, kind of similar to this. When you have a low TREC, especially if the baby is in NICU or a preterm, you have to be repeated. And if it's still abnormal, the sample is submitted to flow cytometry for confirmation. So if the flow cytometry is normal, then it's reassuring that it's not a SCID, and other causes, possible causes like those syndromes need to be evaluated. But if the flow is markedly abnormal, then or suspicious for SCID, then the baby has to be referred urgently to immunologist and needs to be evaluated for transplant. So this is our data so far in our SCID newborn screening experience. So BC is, I think, the third last province in Canada that implemented SCID newborn screening by TREC. Finally, it went live, approved and went live last October. So far, since October, we had about 10 samples with abnormal TREC results that were submitted for flow. 7 of them were normal by flow, so there's no clinical immunology follow-up that's indicated. I think one of them had T-cell lymphopenia that's kind of worrisome enough to warrant chromosome microarray just to make sure, and that was actually normal, so that's good. there were 3 abnormal screening by flow, including 2 repeats. Sorry, 2 of them were repeated, and 1 actually had congenital CMV with flow findings that actually kind of non-specific and may also reflect the underlying viral infection. And 2 of them actually had reduced CD4 naive T cells that are compatible with DiGeorge syndrome, eventually diagnosed using microarray. So that's that for newborn screening for SCID. I'm going to move on to a few other examples of a different group of disorders where flow may play a role in the diagnosis. So there's combined immune deficiencies, group 1 and 2. This is a case of a 13-year-old girl with chronic rubella granulomatous skin ulcers, very low immunoglobulin levels, and the TBNK enumeration only show mildly reduced T cells and normal B cells and NK cells. However, when we did the T cell memory panel, it shows markedly reduced CD4 and CD8 naive T cells, and basically absent class switch memory B cells. And this patient unfortunately didn't have any genetic mutation detected. However, these flow findings are very clearly supporting the diagnosis of combined immune deficiency, of like a T cell defect that leads to inability of B cells to class switch. And eventually this patient underwent a stem cell transplant. And this is second case, which is quite interesting, actually. This is a 1-year-old baby that's admitted to ICU with respiratory failure, secondary to PJP pneumonia, CMV, pneumonitis, viremia, again, absent immunoglobulins, but otherwise had unremarkable birth history from a healthy mom. CBC is pretty unremarkable other than maybe a mild eosinophilia, markedly low immunoglobulin levels. So the clinical picture is actually pretty concerning for SCID, but it's a bit old for the typical SCID, so it could be an atypical SCID. However, the TB and NK cell counts are totally normal. So because of the clinical presentation that involves fungal and viral infections, of course, that leads to suspicion of T cell defect. But to everyone's surprise, it was actually normal. So we promptly communicated that to our immunologist, who then added on B cell memory panel on the same blood work, so he didn't need to poke the baby again. And that actually showed markedly reduced switch memory B cells, as you see here. But the clinical presentation is not really consistent with B cell defect, which is usually associated with bacterial infections. This baby actually has fungal and viral infections all of a sudden. So that led to further investigation of T cell function. So the T cells subsets are numerically normal, but as you see here, there is a functional defect of the patient's T cells. So this is our lymphocyte stimulation assay using mitogens to stimulate the T cells with PHA and PWM, phytohemagglutinin and poke with mitogen, which stimulates a different pathway of T cell activation. So this is unstimulated. And then with the PHA stimulation, as you see here, is a normal control in green. And the patient has markedly reduced T cell proliferation count, whereas the patient actually has a normal proliferation count to PWM. And so the patient underwent whole exome sequencing, which revealed a variant of unknown significance and one copy of a gene called IRR4, which is an essential player in the TNB cell development. So In the literature, however, there are reported cases, but they're usually homozygous, which kind of didn't fit with what the patient had. However, regardless of that, the immune phenotype that's reported in the literature actually really fits with what the patient had, with the low memory B cells and A gamma globulinemia and low proliferative response to PHA, but normal to PWM, and eosinophilia as well, which all the patients had. So that phenotype really confirms that this is likely an explanation of his symptoms of this atypical SCID presentation. Patient eventually received IVIG and stem cell transplant. All right, so moving on to the next group, which is predominantly antibody deficiency, which is characterized by impaired B cell differentiation and immunoglobulin production. Again, the classic example is common variable immune deficiency, but there are also others in this category on the right. And CVID has a bimodal age distribution. The pathogenesis is largely unclear. Majority are still unknown, but about 10% is actually characterized by a specific genetic defect. So the challenge in the diagnosis of CVID is because the B cell numbers are actually low only in a minority of cases. So you cannot just do a basic TB and NK cell enumeration to diagnose CVID. And especially before age of 4 years, there's this entity called transient hypogammaglobulinemia of infancy, or THI, which is transient in nature and should not be mistaken as CVID. And as you can imagine, the differential diagnosis for reduced immunoglobulins are actually quite broad. It doesn't always mean CVID. So if you look at the diagnostic criteria of CVID, it's actually quite long, and there are a bunch of other diagnostic criteria, flow being only one of them. So another thing that flow can help is also to predict clinical phenotype. CVID patients with markedly low switch memory and increased CD21 low B cells have increased infectious and autoimmune complications. And it also then allows better selection for those who may need genetic testing. So obviously not every CVID patients need genetic testing. There, like I said, multiple other lab diagnostic criteria you can use. But if it presents with atypical features, then maybe those are the ones who may need genetic testing. So that's an example of that is this 8-year-old girl with CVID phenotype. She had recurrent respiratory tract infections and pneumonia, lymphadenopathy, splenomegaly. I think she also had some neurodevelopmental delay as well. And her flow of the B cell subset actually showed markedly low switch memory, but also markedly increased transitional B cells, which has been described in this condition called PI3 kinase delta syndrome activation, and that's indeed what the patient ended up having. So it literally leads to an overactive PI3 kinase signaling pathways and affecting the development of the immune system. And there are actually targeted therapy for these conditions, including PI3 kinase delta inhibitor, as well as protein kinase inhibitor or everolimus, which I think the patient is on right now. There are also group 4, which is the immune dysregulation forms of IEI. And the conditions under this group are usually characterized by lymphoproliferation, autoimmunity, as well as HLH. So that involves different disorders such as ALPS, X-linked lymphoproliferative disease, and familial HLHs. This is I think, a nice case to illustrate this a group of this disorder. This is a young 22-year-old male with history of recurrent sinusitis and actually 7 episodes of pneumonia in his lifetime. And I think that already presents even when he was a child. Hypogammaglobulinemia, and he also suffers from autoimmune cytopenia, including immune thrombocytopenia purpura and autoimmune neutropenia. And his ITP is actually quite refractory to IVIG and steroids, and he had multiple episodes of bleeding despite this treatment. The immunoglobulin levels is only mildly low, and the TBNK counts also very mildly low, but essentially normal percentages of TBN, so like low absolute count, but essentially normal percentages of TBN and NK cells. So when we did TNB cell memory subsets on this patient, he had low switch memory B cells, an increase in this subset that's associated with autoreactive B cells, so CD21 low, as well as an expansion in the follicular helper T cells, which is the CD4 positive, PD1 positive T cells, which is also a marker of chronic activation and exhaustion of the T cells. So the combination of these phenotype is actually characteristic, or leads to suspicion of this immune dysregulation disorder. And his whole exome sequencing revealed variant of unknown significance in CTLA4. So CTLA4 molecule is an inhibitory molecule in T cells, where it competes with the binding of the co-stimulatory molecule CD28 to its ligand on the antigen presenting cells in order to turn off the immune response. So if you have a haploinsufficiency of CTLA4, then as you can imagine, you have uninhibited T cell activation, and that leads to all kinds of autoimmune problems. And so this kind of leads to that whole plethora of symptoms that the patient had. And very interestingly, then the patient's refractory ITP that was quite resistant to the regular therapy with IVIG and steroids, had multiple bleeding episodes and very low platelet count despite those therapies. And as soon as they then discovered the underlying immune defect and was started on appropriate treatment, which is sirolimus, the patient actually had an increase in platelet count almost immediately after. And then I think the patient eventually also was switched to a different agent called abatacept. And the patient actually has an older brother who doesn't have any symptoms or is asymptomatic, and his flow screening is actually pretty normal. That's just very non-specific elevation of PD1, but there's no variant found by sequencing for the brother. All right, and then just like last few slides quickly on HLH. So HLH is a life-threatening disorder characterized by uncontrolled excessive activation of cytotoxic lymphocytes and macrophages, leading to a hyperinflammation and organ damage resulting from that. So there are multiple different factors that can lead to HLH. Could be genetic predisposition, like in familial HLH or other immune deficiency disorders, or could be acquired or secondary, such as infections or malignancies or certain kinds of immune therapy, that all lead to cytotoxicity defect on NK and T cells. So that leads to inability of NK and T cells to mount appropriate cytotoxic response towards the target cells. So there are these secretory granules containing perforin and granzyme B and all those cytotoxic proteins required to kill the infected cells. And then there's a protein which is in the intracellular membrane called CD107A. That's usually, when the granules is secreted, it's translocated into the surface of the cells. So all these mechanisms are defective in HLH, and that leads to a defective interaction with macrophages, leading to massive release of cytokines that's characterized HLH and leading to all kinds of organ dysfunction. And there are different diagnostic criteria of HLH. Either you have you find a gene, or most commonly not, and either that or you 5 of the symptoms, and think low or absent NK cell activity is one of them. A lot of these symptoms are very non-specific and can be also present in other types of hyperinflammatory disorders. So this NK cell activity assay is actually quite labor intensive. It involves radioactivity, and it's not readily available as well. Until recently, there's this group from Cincinnati Children's that they basically utilize this very relatively simple flow cytometry assay that measures this perforin and 107A expression in NK cells. And they published this paper in Blood that and showing that it's superior to the traditional NK cell assay to screen patients for genetic HLH. And the perforin assay almost have this perfect sensitivity and specificity in detecting patients with biallelic mutations in perforin that leads to familial HLH. And the CD107A also has a very good performance in detecting mutations in CD107A, which leads to the degranulation defect in NK cells. And with that, then people in different HLH working groups start incorporating these flow assays in the diagnostic recommendations for HLH, among other lab tests. And this is a recommendation from this North American Consortiums for Histiocytosis from this guy called Michael Jordan, who is a guy in HLH in the States. And this perforin and 107 assays are now standard of care in other children's hospital as well to rule out primary HLH, sick kids. And in Cincinnati, as you see here, they said strict 28-hour cutoff. And that kind of goes back to the NK cell being degraded pretty rapidly after 24 hours. And there was actually a false negative test in one of our kids a few years back where we tried to send out the assay to Calgary, but because the NK cells degraded during transport, it led to false negative 107A result. So we validated, first of all, the perforin assay in-house a few years ago, and this is an example of normal control. So we look at the intracellular expression of perforin in NK cells, and we use the isotype control. Think about it as more like a blank control. When you have the perforin antibody, you have the NK cells, majority of NK cells expressing perforin. And then there's this patient baby that's with suspected primary HLH, where the percentages of NK cells expressing perforin is quite low. All right. So in summary, flow is a fast turnaround technique to characterize the immune system and can evaluate not just the marker expression, but also function. It has a role in supporting the diagnosis of IEI and confirmation of track newborn screening for SCID, allow screening for patients who may benefit from genetic testing, and helps direct therapeutic decisions overall. So I'd like to thank again Dr. Suzanne Verkotren, who's been a constant advisor for this project, and our TC, Lauren Liu, and other flow technologists, our colleagues in Division of Immunology, Catherine Biggs, as well as Stuart Turby and Kyla Hildebrand, and my summer students, and Dr. Luke Chen, who has been very supportive in the development of the HLH assays, and my HEMPAT colleagues. Thank you so much. And with that, I am going to welcome any questions that you may have.
Thank you very much, Audi, for that presentation. Are there any questions for Audi? Tyler?
Yeah, great talk, Audi. Thanks for putting it together.
Thank you.
And super interesting application of flow. I was just curious, are there any things on the horizon that you're either working up or hoping to one day work up?
Like in terms of flow for immune deficiency?
Yeah, is there anything that you guys are looking at adding to your list of things you can do?
I'm just gonna show this slide here. So I think,
Oh, I see. Sorry, I missed that part of the talk.
It's okay.
Yeah.
It's okay. I think there's a balance between, I think flow where you can probably capture the majority of these disorders, like the ones that we already have, versus getting into too much of the weird and wonderful individual disorder, which probably is not economically justifiable.
Yeah.
So I think I'm hoping to work on this NK cell degranulation assay in the future.
Yeah, that's the future
That's
one.
like also another, yeah.
And do you know, is that something that you think will be like easy or difficult to work up? Do you have a sense of that?
Well, it's not as easy as perforin for sure, and that's another challenge that we're facing. It's in a way it's like a functional assay.
Yeah.
So it's like more labor intensive. It involves some kind of like incubation time, stimulation, and it has to be done right away. So there's a bit of more kind of like logistical and operational barriers more than anything.
And how do you do EQA for these types of assays?
Yeah, so a very good question. So we actually have EQA in place for T and B cell subsets. And as I mentioned, different labs probably use different definitions for different subpopulations. So you cannot really 100% compare. But they're actually basic external proficiency for those. And in addition to those, then we also have this regular case reviews and clinical correlation and all that kind of stuff, just to make sure that we're on track.
Yeah, because some of these you can't just send a specimen to all labs and have them get results on it, right?
No, yeah. So I think there's it's not very standardized across different labs. Depending on your gating strategies, different markers you use, you can actually have some variability. So so that's a challenging part about some of these. Yeah, I think oxidative burst assay, we also have EQA and in place.
Cool, thanks.
Thank you.
Are there any other questions for Audi?
I do, but I'm not sure that we have enough time. I can ask Audi after if you don't want to.
You can fire away. Just
I'm
still here.
Great talk, Audi. Thanks so much.
You.
Okay, well, thank you. If there's no other questions, Audi, thank you very much for this presentation and sharing it with your colleagues and members of the department.
Thank you so much, Genevieve, and everybody.
All right.
Thank you.
Thank you, and we'll see you all next week.